For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 3, Episode 39 of Surfing the NASH Tsunami. Our review of different models for early diagnosis of NASH starts now.
This week on Surfing the NASH Tsunami.
If you make lots of false positive calls, then you're generating work and potentially causing harm. Whereas if you make very few true positive calls, then you're denying patients access to care. So there needs to be a balance between the two. And decision curve analysis allows you to do that.
I heard a statistic in the US, 85% of all cirrhosis is diagnosed in the ED department. In the UK, it's 55%. So again, that is a sign that these pathways aren't working.
Patients finding out for the first time of their disease in ED who say, 20 years ago, someone told me I had excess liver fat, but not to worry about it. When I think about the benefit of ILFT, it's that nobody tells people not to worry about it early on. That looks pretty expensive in this analysis.
One of the things that we have to be clear about is what the purpose of diagnosing liver disease is. I know that there are discussions in the UK around using testing for liver disease as part of a multifaceted approach to evaluating patients who've got multiple long-term conditions or metabolic multimorbidity.
There was a very interesting presentation. I can't remember who presented it, but it was in the nurses and allied professionals section within EASL, and it was looking at the brief intervention effect on behaviour of a FibroScan. On one intervention, behaviour change 2 years later was still significant in most of the population who made the alteration.
I think this is fascinating. It makes clear that if what you want to focus on is fibrosis, that focusing directly on fibrosis is a very cost-effective way to capture, well, you said there are 450 total cases. Fibrosis first gets 387, so you get, 85% of cases?
What we found was fibrosis first was the most clinically effective strategy, and it was also the most cost-effective strategy.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guest, hepatology researcher and key opinion leader Professor Ian Rowe, as they discuss new models for early diagnosis of NAFLD and NASH on Surfing the NASH Tsunami.
So Jorn is on vacation, which is in some ways sad and in some ways serendipitous, because Jorn and Louise and I had a conversation stream going during the Euro 22 finals on Sunday. And he was very gracious at the end after sending a very confident note 10 minutes before saying, this is going to PKs. And I think the general presumption was that Germany would have won on PKs, but it didn't turn out that way. So Jorn's not with us, but Ian Rowe is and Louise is. So we have 3 football fans, 2 English football fans, the right way to be this week. And then we'll talk a little bit for 30 seconds or 2 minutes about the start of the Premier League season. And then Ian has a really fascinating poster to share with us, which you can find posted on the episode page of surfingnash.com. So it took a while to get Louise into this call, but she's here now. Louise, how are you today?
I'm very well, thank you very much. And it's approaching the football season, although we've had the Women's Euros, so we've already been in it for a month.
Well, yeah, you've had the Women's Euros, and then you had the Community Shield.
We already have our first trophy. Rock on.
Yes, you do. And Darwin Nunez wins round 1 against Holland, which is nobody necessarily expected. So you're off to a good start. And we have Ian Rowe with us. Ian, how are you today?
I'm very good, thank you, Roger. Pleased to be here.
I don't have kids in school anymore, but he's only had 3.5 weeks of summer holiday, and it feels like 3.5 months, 3.5 years. How long would you put it, Ian?
Oh, it's not quite that long. It feels more like 6 weeks, and my wife took them away for a week of those. So it's I mean, summer holidays are wonderful to have the children at home, but with 2 working parents, it's a bit of a juggling act. None of them have hit the floor yet, so we're safe.
As long as nothing's hit the floor, I think that's a good thing. I agree with you. So what is it like in England 2 days after the end of Euro 22? Is the glow still all over the country?
It's still everywhere. And even so, last night it was still the lead item on the news. The women had won the Euros, and it's brilliant. It's been fantastic. I watched a few of the games, and what struck me is how positive the experience has been everywhere. There's not been any of the other nonsense that often accompanies major tournaments. There were the fan zones, and when England scored, there was just cheering, not mass throwing of beer everywhere. It's been brilliant and really refreshing, and I've thoroughly enjoyed it. My daughter, who's 6, who has shown a little bit of interest in football previously, started saying, when can I go and play? Can I go and play with my friends? And that's what it's all about. It's been really, really great. And England won. We didn't even need to win for it to be this good. So it's a brilliant experience all around.
Is that true? You didn't need to, because, that happened in the U.S. after the 99 Women's World Cup. And, of course, the other thing they have in common is a heroic late goal from someone who didn't expect it, who immediately ran around the pitch having torn off her shirt and getting a yellow card and all that other stuff. Brandy Chastain here in 99, and then obviously Chloe Kelly on Sunday. But I'm not sure the women's game would have taken off in the U.S. as well as it did had we not won. Now, that could be an American peculiarity. Oh, and by the way, the only time I'm aware of there's ever been a women's match that had a larger attendance than you folks had on Sunday in Wembley was when they played the final of the World Cup in the Rose Bowl in the States, which was that match. So you think it would have been as good, Louise, even if you didn't win?
Probably, but I think I echo what Ian was saying, that the atmosphere is the key difference. When you get, and I go to lots of games of football, obviously at various different venues, but the increased stress and aggravation of testosterone, realistically, round a pitch, and the language is really shown up by what has been a wonderful tournament, from children to adults to families of all ages. And it's shown that football can be inclusive. But I think more importantly, and Germany are a fantastic side, but I think if we extrapolate this to what we do here on Surfing the NASH, if you say that all we want to do is add 30 minutes of exercise to a child's week, then this could do it, particularly in lots of populations, and it becomes trendy, it becomes useful. So Germany have already got that platform. They've had it for a number of years. This is the sort of thing that could change if we direct it correctly. The platform here for child exercise, to things that go around it, to it being popular in school, and all of the other things that come with it. As Ian said, the best thing about it was this non-threatening or confrontational atmosphere. Everybody sitting together, everybody having fun, nobody trying to rush the turnstiles at Wembley as happened in the Euro men's final. So I think it's been a real good positive all around. And I think sometimes you need nations like England and not the mainstream winners like Germany, the US, France, Japan, to get a grassroots to make the sport stronger, but also take it into the exercise and what we can do for healthcare.
So first of all, we weren't the mainstream winner before 99, which I think is actually the point, which is we've been able to carry that momentum to a 20-year edge over the world, which is now, I think the world is now catching up, which is a good thing. So may you have that experience. But second, Louise, commendations for taking the Women's World Cup win and pulling it back to fatty liver disease. I think that was really brilliant through the exercise window. Well done. So with that, why don't we kick off, okay, so to speak. Premier League starts this week. That can be your happy moment if you want to, but let's do groundbreaker, one good personal or one good professional from the last week. I would say brave one, go first, but there are only two of you, so braver one, go first.
I'll jump in then. I had the pleasure to be in Washington, D.C. for meetings last week, or towards the end of the week, and I've never been to Washington before, so it was a wonderful experience, a great event. I then spent hours before my flight walking Washington, D.C. to be told, Americans, they don't walk. But I also hit the fact of 32 degrees and then hit on the tarmac and everything else. I remembered why I didn't walk in extreme heat like that and humidity. So I did get on the bus to do the guided tour for a couple of hours for a rest. But I started with breakfast at the Lincoln Memorial and carried all the way down the Mall and around. So it was very nice, and it was lovely to see the city for the first time.
Well, that's great. And 4 o'clock on Friday afternoon, a picture shows up on my phone of Louise and Donna together. So that was a pleasant moment for me on kind of quasi-vacation last week. Also, one of the benefits of Fahrenheit over Celsius, and there aren't many, but this is one of them, is that when you've got 90 degrees and 90% humidity, 90 and 90 rolls off the tongue a lot better than 32 and 90, which is basically what you were dealing with, right? Yeah, the humidity in DC is just untenable. Okay, so thank you for that. Ian, groundbreaker?
Yeah, so professional one for me this week. I've just joined the editorial board of Hepatology Communications, and we had our first editors meeting last week, which was really interesting, and it's a privilege to be able to join the board and just realising how much hard work it's going to be. So I'm in the sort of the initial joyous phase before I adjust to the additional workload. It'll be good. I'll learn a lot, and I'm sure I'll make a lot of new friends too.
And a real contribution. And, the reason all that stuff has a joy phase is so that you're entirely desensitized to the workload until you're thrown into it. And then you wake up and say, okay, I'm not joyous anymore. Wow, this is a lot. But that's a good thing, right? So my best will be personal, because in the business section, I'll talk about the professional best, which has been the quantum leap in the number of downloads we've had in the past month over anything we've seen before that on this podcast. But the personal is I spent last week in Maine. I spent more time with my daughter who lives in Maine than I think I probably had in 15 years. And it was a fantastic time. Maine is a very quiet and tranquil and beautiful place. I gained a couple of pounds because my daughter is probably about a kilo and a quarter, because my daughter is the best dessert chef I've ever seen in my life. She could work in any city in America. I don't think she could live in any city in America. She's a small-town kid at heart, but she could work in any city in America based on the quality of the desserts that she produces. And so it was just a great week all around. And with that, why don't we dive into our episode? Ian has brought with him a poster that was presented at ILC 2022 on the topic of early diagnosis. And it's a topic we've been talking some about in here, and the most efficient way to bring really primary care into the process and get people diagnosed earlier. This is a really interesting result. So Ian, do me a favor, take about 5 or 7 minutes and walk us through what you did, how you did it, what it shows, and then we'll start with questions and comments.
Okay, thanks very much, Roger. Before I start talking about exactly what we did, I think we just have to reflect a bit on what we know now and what the question was. So we know that in hospital practice that a substantial proportion of people admitted to hospital with advanced liver disease and liver failure, so decompensated with ascites or confusion due to encephalopathy, have never had a diagnosis of liver disease before they present. And so there's not been any opportunity to institute therapy or to change any behaviours, and they come decompensated. And unfortunately, we also know that a large proportion of those people, maybe as many as 4 out of 10, will die during that first hospital admission. And that means that then there is never any chance for them to recover or even to have the opportunity to think about liver transplant. So there is clearly a need to think about early diagnosis, or at least earlier diagnosis. And there are lots and lots of people talking about what early diagnosis is, but as yet we don't have a good working definition of what that actually means. Does that mean everybody who's got liver disease, whether that's from steatosis only all the way up to cirrhosis? Does it mean people who've got some degree of liver injury, whether that's steatosis and steatohepatitis with a bit of fibrosis? Or does it mean a relatively late stage advanced fibrosis or indeed cirrhosis? Because that would still be earlier than presenting with complications. But we need to decide between us what we think that definition should really be. And we did, in this study, come up with a definition, and we called it treatable liver disease as a sort of surrogate for early. And treatable liver disease is any liver disease that needs specific treatment. So that is like viral hepatitis, where there is an immediate need for antiviral treatment, or it's autoimmune hepatitis, where there is need for steroid treatment, for instance. Or it's patients who have advanced fibrosis, where there is a need for continued monitoring and secondary care, and the potential for therapeutics to reduce the risk of complications of advanced liver disease in the cirrhosis space. And we know that in primary care that relatively few of the total number of patients who've got these treatable liver diseases are actually identified. And that is for a combination of reasons. One is that not everybody's tested, so risk factors aren't identified. That the commonest way of identifying people for further testing for liver disease is through abnormal liver blood tests. I almost said liver function tests, and can see Roger rattling his swear jar at me. So abnormal liver blood tests. And even when there have been abnormal liver blood tests, they're often not followed up. So other ideas in this area, like the intelligent liver function testing developed by John Dillon, aim to target some of the aspects of this. So taking patients who've got abnormal tests and making sure that those are completely investigated. And there are other ways that people have also addressed the problem by doing or enforcing risk stratification, as we've done in Leeds. But still, you need to have had an abnormal liver blood test, and somebody needs to have acted on that to get to the point of risk stratification. So understanding that there's a problem, we thought about what other strategies one might use. So this has all been done through decision modelling. I'll tell you that there is some case validity to that in a second. But we've compared 5 strategies. So there's the targeted strategy, which is what primary care doctors do now. See a patient, think, oh, this person might be at risk of liver disease, and we will, undertake testing. And we know in reality that testing is relatively infrequent, and we follow that through the decision analysis, through a non-invasive liver screen, and through to referral to secondary care. We then looked at targeted testing, so that's current testing with enforced risk stratification, and that follows what was done in the Camden and Islington work from William Rosenberg. And their patients have a non-invasive liver screen, but they also have a FIB4 And if that's not low, so not less than 1.3, then they go on and have a FibroScan. And we use FibroScan as the second-line fibrosis test in the analysis that we've done here, but it could also be used for ELF and other tests if needed. And those patients in that arm who had either had a positive liver screen suggesting a treatable liver disease or positive fibrosis testing were then referred into secondary care. Using the intelligent LFT algorithm, we followed exactly what they do in their protocol. So that is all patients who have an abnormal test, and they're followed up. They have a diagnosis made as per ILFT, and then they're referred depending on what the ILFT algorithm says. There's then an approach where you do all tests for everybody. So recognizing that some patients have normal liver blood tests but still have significant liver disease, those patients could have fibrosis testing in primary care with FIB4 and then transient elastography if the FIB4 is not low. And if you do that, then you're testing everybody for everything. So it's a fully comprehensive approach. But we know in reality that not everybody's got liver disease, that the vast majority of people don't have abnormal findings on the non-invasive liver screen because the commonest diseases, NAFLD and alcohol-related liver disease, make up over 95% of patients who are investigated. So it's not rational to do every test in everybody because you know really that they don't need it. So the final strategy is called fibrosis first, and that is one where we test for common liver diseases. So we do viral serology, do iron studies, and then they do fibrosis testing for everybody. So it's really fibrosis and common diseases, but fibrosis first. Test everybody. You make a diagnosis of liver disease if there's an abnormality of treatable liver disease, and you refer patients on who've got a positive screen or positive fibrosis tests. And in the analysis, we looked at two different aspects of the way these things might work. We looked at cost effectiveness, where the cost effectiveness was defined as the cost per correct diagnosis of treatable liver disease. And we also looked at something called decision curve analysis. So this is where true positive outcomes are compared against false positive outcomes. So if you make lots of false positive calls, then you're generating work and potentially causing harm. Whereas if you make very few true positive calls, then you're denying patients access to care. So there needs to be a balance between the two, and decision curve analysis allows you to do that. So overall, what we found was fibrosis first was the most clinically effective strategy, and it was also the most cost-effective strategy. And if I say to you that in the 10,000 patients that we modelled, in the targeted, so that's what we do currently, out of about 450 cases of liver disease, treatable liver disease, the targeted strategy, what we're doing today, finds 64 of those. So it's a really small fraction. And that fits with what we see in clinical practice because we continue to see these patients coming to hospital with advanced disease having never previously been diagnosed. If you do risk stratification on top, then you increase the number of people who you find with treatable liver disease because of the fibrosis screening, particularly among people who've got normal LFTs. That means that you find more cases and it's cheaper, and that fits very nicely with the finding of the Camden and Islington work, providing face validity to the results. If you go to the comprehensive strategy where you do everything for everybody, you find the most patients. Out of the 450 or so patients with true liver disease, you find 410 of those. So the vast majority, don't find all because the tests that we use aren't 100% sensitive, but you find the vast majority of them. But it's very expensive because you're doing lots and lots of tests on everybody. It costs nearly, for the 10,000 people, it costs nearly £1 million more to do all of that testing. In ILFT, it costs nearly as much, and that's because the liver screening is very expensive. Patients have to come back for results. Sometimes, depending on which part of the algorithm you're phoning, there's a decision point in the centre of ILFT requiring clinician engagement, requesting ultrasound scans, and so the cost remains quite high for ILFT. It does find a lot of the patients with treatable liver disease, so 360 as against 450 in total, but it is costly. With fibrosis first, however, you find nearly all of those patients who've got treatable liver disease because the reality is that treatable liver disease is mostly advanced fibrosis, and it's cheaper. It's not as cheap as the targeted strategy or targeted with risk stratification. There is an excess cost because you're doing more fibrosis testing, but in comparison to the non-invasive liver screens, it's certainly a lot cheaper. So that comes out as the most cost-effective strategy and the most clinically effective. The other thing that's important that comes out is because you're only really diagnosing treatable liver disease, you don't make lots and lots of diagnoses of other things. You don't make lots of diagnoses of NAFLD without fibrosis. You don't make diagnosis of fatty liver due to alcohol, where there is no fibrosis or where the risk of future liver events is relatively low. So you don't end up labelling lots of people, we might come back to talk about this, with a diagnosis of fatty liver where you know that in reality, certainly at least in the short term, that diagnosis isn't going to become important to them in terms of a future liver-related event. It's not to say that it's not necessarily important, but this is a debate that I think we have to have in the community now about understanding what early diagnosis is and what it isn't, and about how trade-offs in this decision-making will become important. So I'll conclude by saying that this is a modelled approach, but the fibrosis first pathway, it takes a relatively quick and frugal approach to identifying patients who've got prognostically significant liver disease or disease that needs treating imminently. And we think that it would be a good approach to test in trials and to really inform the debate around early diagnosis.
Well, thanks. That was appropriately timed and really elegant description of a fascinating process. Louise, you were nodding at the end. I'm wondering what questions you've got before I ask mine. I have a few.
I think it was a lovely piece, and it's great to get the comparison of these different pathways. Everybody talks about cost, and depending on how you do it, the costs can change. So Ian's right. We need to find the best patients earlier. And the majority of what we find is sick disease very late. That has to be a sign that these pathways aren't working, that we've currently got in place. So we do need to revisit, revamp, and look at these strategies that we're currently employing. I heard a statistic in the US, 85% of all cirrhosis is diagnosed in the ED department. In the UK, it's 55%. So again, that is a sign that these pathways aren't working. And people keep trying to just adapt a pathway and bring something else in. And that seems to be way more expensive than taking evidence like Ian's got or Mars and Nuruddin's created in type 2 diabetes and look at the cost effectiveness of some of the strategies that we've got and put them in. One of our problems, as I'm sure Ian will go on to say, is access to FibroScan and non-invasive technologies at primary care level is scarce, and it's only in a very few liver pathways that have developed it. Nottingham, Southampton, because they've made it, and they're always picked up as absolutely perfect examples of great practice, but they've been running for a long time and they haven't gone beyond examples of great practice. So this evidence we need to be driving forward for patients and really getting in there. That's why it's absolutely vital that we start to build on this, and hopefully NICE will allow primary care access to be able to develop exactly what Ian's demonstrated here as a really cost-effective screening opportunity for liver disease. But Ian, can I ask you, if you were to look at it from metabolic risk factors, how many additional patients do you think you'd have found who you could have directed to endocrinology or lifestyle management for type 2 diabetes, cardiac risk factors, which again adds potentially, I think you alluded to it, better cost saving because you find different types of disease risks?
Yeah, so it's a really good question. I don't know the answer. So we've taken a population defined by patients who are currently undergoing testing in the UK, and the cohort is defined broadly according to the patients who were included in the ballet study. So that was a study that was done exclusively in primary care in the UK and looked at the distribution of risk factors and ultimate diagnoses in the population. So we can't say what the difference would be if you tested a different population because we don't have information about that and about the liver disease that's in those groups. And one of the things that we have to be clear about is what the purpose of diagnosing liver disease is. I know that there are discussions in the UK around using testing for liver disease as part of a multifaceted approach to evaluating patients who've got multiple long-term conditions or metabolic multimorbidity, whether that's diabetes, obesity, at risk of diabetes, hypertension, cardiovascular risk factors, and understanding how each of those plays into the presence and severity of fatty liver disease and vice versa is something that I think we increasingly need to understand, because that might help us which patients to test and when, recognising that the vast majority probably of those patients, their other risks are going to be greater than their liver disease. And it's important that we don't end up deprioritising liver disease just because it's not as important as the others in the vast majority of patients, but allow patients to have access to appropriate testing so that they can either be reassured about liver only or they can receive a diagnosis that's important to them. In a conversation that we've been having about this, so our National Clinical Research Funding Body, the National Institutes for Health Research, has got a call out at the moment for partnerships for liver disease. And the idea of these is to try and build teams of researchers who can address questions principally in common liver diseases, so NAFLD and alcohol, focused around early diagnosis and prevention. And one of the obesity researchers was very clear about how patients who have these metabolic multiple long-term conditions, often don't want more diagnosis. They just feel that that's just layering on guilt, in essence, about, it's another weight-related complication. And if they don't have significant fibrosis, perhaps they don't need that diagnosis as well, unless it is going to change unless it's going to lead to meaningful behaviour change above the information that they've already got. And thinking about how we make a diagnosis and when we make it in that population, I think is really important.
I think that's right. And I think I do the counterbalance to that is that by showing somebody that you can measure something like liver fat and watch minor changes, it actually does motivate. It does change behaviour. So avoidance of a diagnosis, is that good or is that bad? Just because you might give somebody an additional diagnosis, it doesn't mean that not giving that is a good option. And I think it's giving somebody the information to make an opportunity for change. If we ignore that opportunity, that's not necessarily doing the best for the patient. And it's the way they do addition and support. So that would be the counterbalance to that, because you can measure it now. Before we've just gone away and said, lose weight. We can do that in slimmer people who have just as worse diets and probably worse liver disease than some people who are bigger on the outside, for example.
So, spoiler alert, before we go back to stay in this conversation, which is next week, Mazen Nuruddin and Michelle Long are coming on and talking about their paper about treatment protocols for patients with lean NASH. Just a duly noted that says that's a whole different kettle of fish, if you will. But we'll be getting there next week. Ian, go ahead. You're going to respond. I have a couple of things I want to add, but you go first.
I think we urgently need to understand to what extent and how reproducible behaviour changes in different settings with diagnostics. It's a complex intervention in many ways. It's a test. It's information given at the time. And one of the important things that I would say about the piece of work that we've done is that the cost effectiveness is simply around the cost of making a diagnosis. It's not the downstream consequences of that. It's because by and large, we don't know. I mean, we're not confident that in all settings and reproducibly telling people that they've got liver disease due to NAFLD or alcohol influences their behaviour. And in terms of downstream outcomes, that's one of the, that's probably the greatest known unknown. And I was talking to somebody about this earlier on today and about whether fibrosis first was a potential screening strategy for the population at risk, whether you call that screening or case finding or whatever, is a separate argument. But the analogy I drew is that we're quite good at giving treatments where there's established disease. So in cirrhosis, we've got treatments that probably reduce the risk of decompensation. Very straightforward, using beta blockers and perhaps reducing consequences of HCC when it's diagnosed. But what we don't have is what we have for screening colonoscopy, and that is we don't have a clear preemptive intervention like polypectomy. So you do screen colonoscopy, you take the polyps off and you prevent cancer. What we don't know is we do the test here, to what extent we reduce the risk of future liver-related events in those people who we diagnose with treatable liver disease, but almost as importantly, whether we're having an impact on those patients who aren't diagnosed. That I think is something that we've really got to work on.
And in fact, there was a very interesting presentation. I can't remember who presented it, but it was in the nurses and allied professionals section within EASL, and it was looking at the brief intervention effect on behaviour of a FibroScan. And on one intervention, behaviour change 2 years later was still significant in most of the population who made the alteration. So it was a very interesting piece. I've seen the call out for collaboration and partnerships in the NHRI, and I think the one thing that they're calling for is increased access to villages, to rural communities, to seaside resorts and things like that. But actually, there seems to be little that I can apply for to say that everybody can have access to FibroScan, even if you don't normally have it, which seems to be a problem for people. If you don't have it, you don't actually even look to use it because you don't think you can get those resources. That's where I'm looking at the NHRI for that collaboration, to be able to use things like the data that you've got to strengthen these pathways. That's the concern. And the more evidence that you guys produce on how effective doing it this way, because I'm presuming that took away the costs of specialist referrals to get to requests, all of those additional costs that you mount up before you even get a test, which makes a test very expensive and very selective. Is that right?
Partly right. The model does include downstream consequences, so not being referred to secondary care being the big one. Seeing a secondary care doctor is expensive and often of low yield. I can say that's how I work in secondary care. But you're often not learning a lot more from me than you've already learned from your GP or the nurse in the practice in terms of the actual advice that you're given. I mean, I might be able to tell you lots and lots about liver disease and the relative importance and place it with everything else, but sort of actionable available information is often not much more, particularly if I say, before I can make a decision, you need to have a FibroScan, in which case you've got to see me again afterwards, which is not a good way. It's probably not a good use of the patient's time and probably not an excellent use of our time either. So we could use that time more effectively within the whole system. Can
I ask you a point on that? Did you find in your data, would there be a category of patients, because you did say that there was increased referrals to hepatology, presumably more appropriate referrals, because every commissioner in any part of the world that does that goes, that's money. And if we don't look, we don't find, therefore we don't spend that money. Is there a section of that population whereby, certainly in the fibrosis first, or any of the others, where virtual appointments could come in to, again, save costs, direct the right people, and more appropriate tests in their own community environment?
So, yeah, the referral thing's interesting because people have seen the risk stratification idea as a referral, and different systems are different. In the UK, some of that is around demand management, and that I suspect is not the case in other systems. But people see that risk stratification as doing that. It might not actually. It probably increases referral slightly, but you're seeing more of the right patients. ILFT is quite referral heavy, despite what some colleagues are saying. And I think as we get more experience with it, we'll see the impact of that on services. The more tests you do, the more you find. And I think it's quite challenging because you don't give what I would consider to be a normal diagnosis to everybody. The commonest diagnosis in the last publication of ILFT is abnormal ALT without fibrosis. Now, I don't know what that is. It's not a diagnosis. I don't think it's a description. And the reality is, without careful management, a proportion of those patients are going to end up being referred, despite us knowing that they probably haven't got significant liver disease. And there are many challenges in this space because we've started off with a test or panel of tests that might be quite good in people who've got advanced disease, but in people who've got early disease, they're essentially hopeless. And there's a lot to think about.
Can I pull this back a little bit, because I've got 3 or 4 thoughts running around in my head, that things that we talked about on this podcast and elsewhere in life that are related to this, but not exactly this. So here's the first one: patients finding out for the first time of their disease in ED who say, 20 years ago, someone told me I had excess liver fat, but not to worry about it. When I think about the ILFT, the benefit of ILFT, it's that nobody tells people not to worry about it early on. Now, that looks pretty expensive in this analysis. I'm not sure how it would look in other analyses. Stay with me for a minute on this. I don't know the answer, okay, but I do know the question, which is that all the patient advocates telling us, gee, I should have heard about this 20 years ago. If we go fibrosis first, I'm not sure it solves that problem. It does solve the problem of the people who then proceed from, we're told 20 years ago they had fatty liver, not to worry about it. And then there's a 20-year wasteland, and then they show up with cirrhosis or encephalopathy in an ED. You'll pick it up at F2 or F3, which is really what this is designed to do. So the patients who proceed to need treatment find out they need treatment earlier, but they've still got a significant amount of disease at the point where they hear that. That's thought number one. Thought number two, Quentin Anstey was on a couple of weeks ago talking about, among other things, a presentation that he gave at EASL, which took a look at FIB4 high, FIB4 indeterminate, and FIB4 low, and suggested that FIB4 indeterminate, largely because of age, but not entirely because of age, was a pretty good predictor of all-cause mortality and a really good predictor of cardiovascular disease relative to FIB4 high. So I'm wondering where that fits into this model in terms of, do you think about a world where FIB4 sets a path on whether you go on to TE or not, but you want to grab that on everybody because you're going to find people at indeterminate levels who've got other mortality risks that aren't liver. So that was my second thought, that I've got patients who say, gee, you could have told me 20 years ago. Although for each of those, we have 10 people you could have told 20 years ago where it wouldn't have changed anything in the path of their health. And then my third thought, Louise, goes back to, I wonder whether, you said people who have an effect of an interaction with FibroScan that lasts for 2 years. What percentage of people have that effect? And the reason I ask is that you're a compellingly good salesperson. So I'm certain that if you're the person doing the FibroScan, the percentage of people that you're going to motivate to take this seriously are going to be significantly higher. Not than everybody, but than many other people. So what percentage do they see in the study?
I think you have to look at it, as Ian said, certainly in healthcare, because I come from two sides. In people with a healthcare diagnosis, if you do it, and when we were doing it with skilled nurses or doctors, you get an effect and people want to know the result. They also ask the question most times, what can I do about that? So you can give them a solution. When I look back at some of the data we've done, around about 85% of people made a lifestyle change, even in healthcare, on that first appointment. I think the difficulty we have in healthcare is a lack of access to continually monitoring. And now we've discussed that before. Stephen and I both felt, and others, that really, if you're going to make a behavioural change, you should be monitoring it every 3 months because you get reassurance. When I've seen people who did not make a change on the second time, and I never ever discuss a result until they tell me, so I've seen the result and I'll say, so what did you change? And the response in that population will be, actually, I didn't change a lot. And I can tell you 100% of the time, my response will be, yes, I can see that you have made no change. Your scan is telling me X, Y, and Z. So you then have that second conversation. And again, you will take most of those, they will then change because it is reinforcing what they haven't done. But on the opposite side, the ones who make the change, if you can get them quick enough, we've got a case of our lifestyle that they changed their liver fat because they gave up sugar. They'd increased exercise. They generally improved their diet for 5 years, but they wanted to keep their general sugar habit of sweets, apple pies, God knows what, every day. And they felt the exercise model was going to help them. They got their liver fat down from 370 to 290. That's still steatosis grade 3, still significant risks. But what they did was then, pandemic, third lockdown, give up sugar. And they actually got their liver fat down on 1 kilo weight loss, but normalised their liver fat. Now, that won't happen to everybody. But what you're trying to do is do it regularly enough, because we just say lose 10% body weight. That is really, really difficult for most people to maintain without any feedback loops on what you're doing apart from scales. And people get frustrated. What they want to know is what's right for you for your liver, or for you for your lifestyle. We don't ever offer that in healthcare. But in lifestyle, and Ian described really early in that last session, people don't want to know another diagnosis. On the other side, people coming in from a health fitness perspective, I'm going to go onto a diet. What is my liver telling me now? How do I monitor it working? But have a totally different psychology. They're not in the patient mode of fear, of anxiety, of that they're in. What can I do to help? How can I make a change? How can I monitor that change? That's the behaviour belief type model that we use for breast screening, for cervical screening, where you can make a difference to your outcome, i.e. prevent cirrhosis, or if you have cirrhosis, improve your outcomes and reduce your chances of liver cancer, things like that. Generally, people make that change. And I think we see that in lots of research where you monitor those changes. What we don't have yet, apart from the small pieces of work like the one at EASL recently, is how that small intervention can be highly cost effective by measuring downstream outcomes, attendances to primary care practices, picking up reduction in diabetes risk, improvement of HbA1c by monitoring their liver fat. We do know that you don't reverse diabetes without losing liver and pancreatic fat, but we still just tell people to go and lose weight. We don't measure the outcomes that we can change. And that, for me, is where we need to change. These tools should not be seen as liver tools for liver people. These are toys and assessments for people whose livers are at risk. Where Ian's, and I don't know whether or not the strength of some of what Ian's been discussing in that portfolio is using it in the low-hanging fruit, the high-risk populations that we know have the majority of significant fibrosis, the type 2 diabetics with hypertension or high cholesterol. Making those changes upstream with somebody's behaviour in 9 out of 10 cases, when we get to things like obeticholic acid, when it's £28,000 a year for somebody to be treated with primary sclerosing cholangitis, then we're talking about a double dose, do it 2.5 times the dose. How are NICE going to approve that in people who haven't been behaviour managed, who haven't had access to nutritional assessments? This is where Ian's research and research that proves finding liver disease and risk patients in the community is going to give us tenfold, I would suspect, and more benefits, because we're going to have to show that we've looked at behavioural change, lifestyle modification, what diet works for you. Mediterranean diet doesn't work in Japan. You've got to be very specific to the populations that you're looking at, whether it's lower socioeconomic classes, whether it's rural settings with food problems of getting it there, all sorts of problems that come in. But if we don't locate, we don't get an opportunity. And as Ian started the whole session with, this late diagnosis of liver disease is a current demonstration of the failures of the current pathways, which only look at at abnormal liver function. We've got to look, I'd even put FibroScan before that. Let's FibroScan or another test of similar level in primary care to find out who we even need to do the blood tests on, because 70% will have normal liver function.
So, Louise, Ian, I'm going to turn to you in just a second, but it seems to me that what you just described up against Ian's model is a lot more expense. I'm not sure how much it improves the model in terms of liver disease per se. What does that description do to the economics of this model, and what benefit does it provide?
So in the model, we looked at doing an elastography-only strategy, and it's a lot more expensive than using FIB4 up front. And I think it's really important just to reinforce the point that this is a one-off test in a population who are considered to be at risk of liver disease, and the outcome is a diagnosis of liver disease. What we haven't looked at, what we don't really have sufficient data to model even, is about repeat testing. That's a really important issue about how frequently this should be repeated. I would argue that there's not much difference between fibrosis first and ILFT because it's the same fibrosis measure. So if you're told that, at the moment you don't have prognostically significant liver disease, that doesn't mean that you're not going to develop it, but you need to have another test in a defined period. I think, people are talking about 3 years at the moment. I suspect that might be too short even. Maybe 5 years would be better, but that all remains to be worked out. As I said before, we sort of need to understand what the impact of these interventions are on behaviour change in all aspects, and whether repeating testing and that biofeedback increases engagement and increases the impact of the original diagnosis. That again we don't know, and I think it would be worthwhile exploring that in the alcohol setting. People have done some studies, but they're poorly controlled, and it's not at all clear whether repeated measurements really do influence continued behaviour change. But what Louise says about her experience is really important, but unfortunately for services in general, people who are doing FibroScans and the areas in which FibroScans are being delivered, they're not all being done by Louise with, I wouldn't like to say how many years of experience, probably, I don't know, 10 or 15. So it is very different. And the idea of a test and early intervention or brief intervention strategy, it's complex, and for the whole system we would need to know that intervention was reproducible, or in technical terms had high fidelity. If it was given by a practitioner in Leeds, it had to be the same as in Newcastle or in Aberystwyth or in Truro, because only then would we know that it was going to have the impact that we think it's going to have. And in doing this, we started off with a simple idea that this was very straightforward, and if we only did this, then everything would all make sense. But the more that we look at it, the more we think it's a good thing to test, but the more that we realise that there are huge questions around it that we simply don't know the answers to, and that we must address. And just on one last thing that Louise said, that the UK call for these partnership grants probably isn't good for Louise, but NIH have just launched a call at the end of last week for a study in early diagnosis of liver disease that specifically includes elastography, and that is intended to be done at the primary care level. So I think that we will, in time, probably quite a lot of time yet, have studies that will address this and give us some answers about what the best way to do it is. But even so, there'll still be lots of remaining questions about whether, how, and to what extent testing improves outcomes at the end of the day. And ultimately, that's what really matters to patients.
I was going to ask, your ILFT, I presume that 100% of people you picked up with ILFT went through the pathway, did they?
Yeah.
And yet you found that very expensive, because John Dillon, I was there in Barcelona when he was presenting, even with people who did ILFT and had signed up for it, Roger, remind me if I'm inaccurate here, only 55% of them did not refer the patients picked up on ILFT into the services. So you do all of those tests, which are expensive, and you only refer in about 45%. So that obviously has huge cost implications and would make that even more expensive by my way of thinking on your modelling than even you showed.
Or is that in the model already?
That's two changes in the model. I have to really think about that when that happens, because you'll reduce some costs by people not attending appointments. But
that's not good, though, right?
No, it isn't good. But the diagnosis has been made, so in the model it might, unless you say that the diagnosis can only be made by a specialist, it probably make the model look better. But that's because the outcome is cost per diagnosis, not what happens in the long term. And I would like to think that for patients who've got treatable liver disease, coming to see a specialist is a value and will impact on their long-term outcome. ILFT is a very attractive strategy because in the UK at least, there are guidelines that are not adhered to about testing patients for liver disease where there's abnormal tests. And it streamlines the process. It makes it easier for primary care doctors to get the tests that they need to get the answer to the question that they're asking. The issue is really that for many of those patients, they don't need all of those tests. And I think we can probably be a bit smarter about how they're employed. And I know that, that John and his team in Dundee are iterating that algorithm constantly to try and improve the way that it works. And, the analysis here is a snapshot of what was published the last time it was published, but it may be that it's different underneath now. And that's one of the values of these automated strategies, is that you can learn quite quickly from information that you get through.
So, Louise, do you have anything? I feel like I kind of monopolized the last two openings. Go ahead.
I had a question because I wrote it down when I was reading the research, when I was reading the piece earlier. And it was like, we know that poor liver health and liver disease is now the second leading cause of working lives lost. The EASL Lancet Commission last year published that in December, I think. Healthcare, your sort of study, 1 in 6, for example, in the UK, I believe, are employed by the NHS. The NHS is not a fit healthcare set of personnel. 40% on the RCN statistics of nurses are overweight. We should have a sign like, do not feed the animals at the zoo. We do not feed our healthcare staff chocolates and and our doctors and our fizzy drinks. Is it time to put these sort of pathways into workforce? Because workforce is where we're losing lives and we've got opportunities. Workforce health is massive, and the NHS, should we be looking at home to try some of these strategies ourselves? I know that's a way out thing, but I was thinking, we've got a mass population. We've all got our own healthcare, but should we be trying to look at our own health?
Please note, for anybody that has not seen either Louise or Ian or me or all of us, that none of us would necessarily fit into the 40% category that Louise is talking about. So we're just making this recommendation for everybody else, right? No denial at all, because we're all pretty fit. So that's where all those apple pies catch up. Okay, Ian, go ahead.
The other disclaimers for any patients listening: I'll still accept chocolates as gifts after clinic. That's fundamental importance. But in all seriousness, I'm sure that there are things that we can do to improve the health and well-being of our workforce. Whether this is the starting point or whether it's somewhere else, I don't know. But I think a large proportion of people have relatively sedentary activities in working life today because of we're all constantly tied to computer screens. I mean, here we are, the three of us, looking at our screens, talking to each other. And
thinking about our next chocolate fix, right?
Yeah, I know. So yes, I think we do need to do more. The issue around working years of life lost to liver disease, and the reality is the vast majority of those, well over 80%, are due to alcohol-related liver disease, and we have to remember that, because in terms of addressing the real drivers of disease, that has to be number one. And no doubt there is excessive and problem drinking among employees of all big organisations, and if we can help people address that as a risk factor, I guess that we'll do a lot of good from a liver point of view and from a general health and society point of view too. But those would be my pleas really: activity, chocolate still to clinic, please, and screening for and talking about and being open about alcohol, and I think in healthcare that's hard.
But just going back, in all seriousness, health and well-being departments within big firms, they offer screening, but actually the strength of what you detailed with fibrosis first actually doesn't look to stigmatise. It looks to just screen for opportunities for more common diseases and could easily be added to a healthcare screen, because at the moment it's completely ignored. So we're not even looking for that. So therefore, opportunities like simplified pathways give us different areas that we can implement them in. And yes, that would require more research. It would require firms to say, yes, we're going to take an interest in liver health in our populations. But I think that's the beauty of when you look at what you're doing there by comparing different strategies of where they can also be implemented, not only just in mainstream healthcare, which is where we always target, but there are so many areas now contributing to mainstream healthcare that can help the NASH pandemic, the alcohol problems. They've all suffered in the workforce following the pandemic for exactly the same reasons you've detailed out there with alcohol. BMI in the UK has gone up, it's gone up around the world, US, and it becomes a workforce issue. And we know liver health is public health. Public health is also workforce health. So maybe we had a great announcement today. I think it was, and Ian, You might be aware that tube advertising for sugar drinks and high-fat food has been stopped or reduced, and they reckon it's saved over £1 billion for NHS healthcare for children's obesity. I don't know where they get those figures from or how they calculated them, but those are great announcements about advertising, because I didn't see any of where we got that data from. It's just guesswork.
Yeah, in many ways that shows where we really should be working. It's policy and all of those other things. That's an interesting study. I've only seen the news about it. I haven't seen the study, but it looks like it's come from the Whitehall study, which was a study of principally men working in Whitehall in the 1970s and consenting to long-term follow-up. And they extrapolate the data from that study to the general population, and in this case of London. And they think that over the course of whatever it is, 3 or 4 years since they stopped the advertising on all transport for London, that they've saved several thousand cases of diabetes and people not becoming obese against the trajectory that they would otherwise have had. So there's some uncertainties around that, but in terms of overall benefit for the population, that's that's it. We could do lots of testing, but just advertise less and control the environment.
Well, actually, but probably both, right? Because if you advertise less, it's a little bit like putting your foot on the hose, but you still got an awful lot of water in the hose before where you put your foot on is where you're coming from. I'll tell you, I think this is fascinating. It makes clear that if what you want to focus on is fibrosis, that focusing directly on fibrosis is a very cost-effective way to capture, well, you said there are 450 total cases, and fibrosis first gets 387, so you get, 85% of cases? Something like that with that algorithm. It also suggests that doing a better job of getting TE down to primary care will have both that benefit, and if you miss by a little bit, then you start capturing what Louise is talking about, which is people who might not be fibrotic yet, but who've got a bunch of liver fat, where if they knew about it, they might be motivated in some kind of change in lifestyle or change in behavior that might last 2, 3, 4, 5 years with minimal screening. That's not in the economics, I think, of what you've created here, Ian, but I think it's very much in the reality of care. So if you're going to look to do 3 things, one would be fibrosis first to get to the people who need to be in a hepatologist now, some kind of expanded use of TE to help people who may not need to be in a hepatologist now, but have liver and pancreas fat issues that are going to cause downstream health problems. And then, as you say, going back up to the top and putting your foot on the hose where policy is by stopping advertising and a couple of things like that. Does that all make sense? Am I getting that right?
That does make sense. And in some ways, the potential value of FibroScan is the interaction with the practitioner, and that gives you the opportunity to deliver a brief intervention of whatever type at the time of the scan, which if it's solely blood-based, you don't get, because you go and, in the UK, see a phlebotomist and they take your blood and you go away again there's no message that can be delivered at that point, whereas at the time of the scan, there's the potential to do that. And with the appropriate testing and evaluation, you can begin to understand what the wider impact of that would be. And doing that in primary care makes absolute sense.
All right. So we are now slightly past the bottom of the hour, which is a good time, I think, to start to wrap up. So Ian, then Louise, then me, I guess. What would you like to see come out of this study, A, in terms of further research, and B, in terms of changes in action or behavior within the healthcare system?
So personally, I want to see this result in a trial of the effectiveness of fibrosis first versus current standard of care, and that might be possible in a UK framework, or it might not, depending on exactly what the commissioners of research want. But that's certainly the direction of travel, and built alongside that, evaluations of the impact of diagnosis on behaviour change, exactly along the lines of as we've talked about. And I think that in parallel, those 2 studies will take us quite a bit further than we are now.
Okay, so that's what we should study. What do we know enough from these results to do differently? Is there anything?
But I think you can see from the results the value of deploying fibrosis testing now, even if it's only in risk stratification, and that is in international guidance, but not in a universal practice standard of care. So the focus should be on using those tests, whether it's FIB4 and ELF or FIB4 and FibroScan or ARFI or whatever it is. Just it probably doesn't matter which one it is. Just do one of them, because we know that will find a greater proportion of people who've got potentially treatable liver disease than if we don't do that.
Louise, research you'd like to see, behavior you'd like to see within the system?
I'd like to see everything that Ian's just discussed there, because I think it comes from a sound background. I'd also like to see quality of life and behaviour measurement tools within that to see whether or not, and I would put a head-to-head against ELF and against ARFI or whatever, so that you can determine which devices make people's change, and whether or not it's the blood tests with the report and the results, whether or not, because I think that does need to be teased out. We're getting more and more of that evidence. There is always but it could be done with this or it could be done with that. Actually, there's multiple ways of doing it. Is it the nurse? It has to be about somebody. And yeah, I've got 15, 16 years FibroScan experience, but I'm also a mental health nurse by background. But I'm also 37 years in hepatology. I know what to talk to patients about. A lot of patients, it's about what they need at that moment in time. That may change, but you've got to make it understandable. One of the abilities of primary care is to be able to deploy these tests into primary care and learn a language that's understandable, that somebody then can pop back to their GP and do that, have that conversation, or to pop into the practice nurse. When you go to highly specialised units, often several hours drive from people's homes, or train journeys, or real difficulties, people are less engaged to then ask those questions, which means you get less of an impact, or it becomes more scary. And I think the one thing we don't want to do, liver health is a slow changing progress for most people if we find it early enough. What we're getting now is this real problem of a lot of advanced disease that is untreatable, as Ian said, and we've said many times, or cancer where we don't have an option. So liver disease is racking up as a really scary disease to be diagnosed with. Let's get there early and make it something. I want to know about my liver health because I don't want to get the scary. And I think we do have to change the narrative. But when we've got primary care or people who say, liver disease, too scary, send to a hepatologist, that's not helping. Liver disease is simple. It is the one organ that controls the health of most of the rest of the body. It's your balance and equilibrium. Just check it and then find it early. We'll do something about it. Tell them to us. Let us talk to people. But education is going to be key as part of this line. And these early strategies are really key. There was another poster at EASL that was really good on the fears of primary care. And it was lack of education, lack of knowledge of how to deploy these tests. And that's where we need to target. Stuff that Ian's doing now, target with what is their weaknesses and they view as their weaknesses, and we can achieve really nice things in primary care. Most liver disease should probably be treated in primary care with the right patients going to specialist care. These strategies and these pathways that can be developed have immense potential, because what will work in the UK may not work in Middle East and Africa or lower areas in developing worlds, and different communities will have a different role. But we've got to start with something that diagnoses liver disease earlier and cost effectively. I think Ian's certainly shown that nicely. So I would like a trial looking at all of the benefits that we can get out of it. The brief intervention, purely the blood tests, how do we change behaviour? That might be a big protocol. We've got some good assessment techniques to be able to do that.
And then in my dreams, we would not only be looking at the result on liver, but on other related metabolic conditions. Because I've been waiting for Louise to do this, and she hasn't. But I think if I do Louise's 5 greatest hits from the 2.5 years we've been doing this, one of them is Donna Cryer turning to Vlad Ratziou and saying, if I'm dead, it doesn't matter what killed me, I'm dead. This is a really great look at liver and a really interesting discussion about the most efficient way and most effective way, which isn't necessarily the same thing, to broaden out from liver to motivating people with a earlier stage liver disease and other metabolic conditions to actually take their health in hand, and whether TE becomes part of that process or what tests become part of that process and what coaching. But Ian, I kind of feel like if the liver is central to everything else that goes wrong in the body, that this is, I think, a really good look at the most efficient way to look at liver, and raises, I think, some really spectacular questions about the degree to which other broader screening techniques, ILFT, for example, or ILFT leading to TE, can help us help patients who may have liver fat, but liver disease might not be their primary issue right now before it gets to be. And then we don't have all those people saying, gee, you could have told me 20 years ago that I could do something about this. So that's my wrap. And we're within 2 minutes of when Ian told me he had to leave. So anybody have anything else to add? So thanks both of you. I think go ahead, Louise.
I do. Rock on the Premiership, because the three of us have 3 competing teams.
Yeah, that's right. That's right.
And
That's
even
right.
for the World Cup, the monkey is off the back of the male team for winning a tournament. Go England.
Now the monkey is on their back because now they can't say, well, it's just the English jinx. The English jinx has been broken. Now you've got to now Lions is trying to prove out. But yeah, we agree on all that. Good luck. Now who does Liverpool start with? So who does Liverpool start with?
I can't remember who we got straight off. I know I'm going to the Crystal Palace Arsenal game. That's why.
Yeah, you told me that. And Ian gets Nottingham Forest, who are, I guess, the debutantes of the year this year, right? They've not been up in a long time.
And Forest are one of my many second teams for many and varied reasons.
So you can't lose, huh? Unless they draw, which might be really disappointing.
Yeah, I think for Forest to draw would be a good start. Put it off the mark quickly would be good for a promoted team.
Although I'm mindful of Brentford in the opening match last year, just blowing out Arsenal, right?
Oh yeah,
the new boys. So
you've got but they're not really the new boys because they bounce up and down every year. You have either Fulham or Norwich. The question is which one. They swap places. At any rate, we'll be back next week to talk about Lean NASH. Ian, thank you so much. This has really been a fantastic discussion, and we will post this poster on the website when we post the episode. Louise, see you next week, and everybody, good luck with your teams as the season rocks on. Thanks. Bye-bye now.
And now for the Season 3, Episode 39 Business Report.
Slava Ukraini, Heroyam Slava, glory to Ukraine, glory to heroes. May this war proceed to a just and quick end.
Last week's postings taught us a few things about what you will download.
Last week, we tried an experiment by devoting the entire week to episodes in the vault. During the podcast, Jorn and I discussed some favorites, and then during the rest of the week, we reposted 2 episodes and 6 conversations. We had several reasons for doing this, but one of the important ones was to learn whether older episodes have appeal to current listeners. And the answer was a resounding yes. The 3 weeks prior to last week all saw over 2,000 downloads per week, which had happened only once before July. I'll talk more about what that means in a minute, but my point here is that it becomes a measuring stick for last week. As I speak to you on Tuesday morning, we've seen close to 1,950 downloads this week. Not quite 2,000, but we'll probably get there by end of day today. Admittedly, we posted 9 elements this week as compared to 5 to 7 on a typical week, but it's still a larger number of downloads than we had anticipated. In fact, it's larger than the high end of what we had anticipated. What this tells us, you're interested in going back to the vault, actually, and having us go back to the vault for you and pick out episodes or conversations worth listening to. And what we will do is post 1 episode or conversation each week so that those of you who've joined recently and never look back have the chance to hear some of what you've missed. Hope you enjoy it.
Our CME episode on new insights into the proper use of non-invasive tests comes out this week.
We've had a few technical challenges this summer, which put the Rising Tide series on hold for a month or two and delayed CME for a couple of weeks. However, we delivered the final CMA podcast to our CME partners at CMify yesterday, and it will be out by end of week. To find it, go to the surfingnash.com website and look at the top banner for the education link. This will take you to our education page, which right now has only that 1 episode for you to download. You click on the link, you'll go to the entrance page, and then you can go on to the episode.
We have some excellent episodes coming over the next few weeks.
Over the next 4 weeks, we'll be presenting some exceptional, really exciting new content. Next week, Maza Nuruddin and Michelle Long will join us to discuss their recent article on managing lean NASH patients. Our first chance to talk to Michelle since she's gone over to the industry side, although this is an academic paper. The following week, we'll be discussing what we've learned about improving drug trials and reducing fail rates over the 2 years in Jorn Schattenberg's 2020 article on this subject. On August 22nd, I'll be on vacation. Louise will be running the episode with an exceptional set of guests looking at a health systems issue of her choice. And finally, we end the month of August with Mazen, Stephen, and Naeem Al-Khoury joining us to discuss advances in how we think about combination therapy, triggered by their article a while ago about the combination of semaglutide, cilofexor, and fricosistat. In September, we'll be covering Paris NASH and the EASL-NAFLD Summit, along with a couple of published articles and at least 1 extrasode.
The news on downloads is just crazy.
Okay, as we mentioned 2 weeks ago, we had smashed the 2K download barrier twice in a row. We smashed it last week for the 3rd week in a row. And this week, as I noted, we're already at 1950, which means we'll probably break it a 4th week in a row. Given that happened only once before, this is pretty amazing to us. And to put it in context, the total number of downloads in July were 8,876, well more than double June, which was admittedly a light month for us. But previously, our biggest month had been January, which had just under 7,000 downloads. So to put it in context, the July number is 29% higher than our previous best, and I think about 45% higher than our average month so far this year. With that, I'm off. Thanks to the crew, Magic Mike, Eric, Steve, Murph, for everything they do. Remember to look for the CME episode towards the end of this week on our website. And as always, thanks to all of you for making this such a worthwhile labor to pursue and for listening and downloading and sending us your feedback. Stay safe, surf on. We look forward to seeing you again next week on the podcast, along with Michelle, Mazen, and Louise. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.